This is Dr. Amit Patki, and I'm an infertility specialist from Mumbai. And today, along with me, I have two very eminent fertility specialists from Western India, from Maharashtra. And let me first introduce you to Dr. Reshma Pai. Reshma is currently the FOXY president, and she has in her FOXY tenure done a large number of programs. But the most important program that I think that she has done is on PCOS awareness, which has happened across the length and breadth of the country. Reshma, after this exhaustive FOXY presidency, is going to take over as the president of two very important societies, the ISAR and the IAG, which both are indirectly connected to PCOS. Hello. Along with Reshma, hi Reshma.
Hi.
Along with Reshma, I have Dr. Kundan Ingle,
hello,
who is an infertility specialist from the city of Pune and is in the managing committee of the Pune OBGY Society and the managing committee of the Maharashtra chapter of ISAR. So with both of these, we today will discuss a few of our important points on PCOS in the infertile women. So Reshma, when we come to infertility and PCOS, why is it that we see such a large number of PCOS women coming for treatment?
I think, approximately 30 to 35% of the couples seeking fertility treatment, the woman is suffering from some level of polycystic ovarian syndrome. And this is a huge percentage. Many of these women are the classic PCOS. The moment they walk in, you can see they are obese, they have acne, hirsutism, they have a history of irregular cycles, hair fall, and the sonography showing an evidence of polycystic ovaries, enlarged large volume ovaries. So they are the classic PCOS. We also see a large number of thin girls with PCO. So they don't have obesity as an issue, but they also have a lot of hirsutism and evidence of male factor hormone influence. Many of them have irregular cycles or delayed cycles, oligomenorrhea, amenorrhea, etc. So today's practice, I think a huge component is patients with PCO.
Yeah, just to reiterate what Dr. Reshma has said, that PCOS is the most common endocrine disorder in the reproductive group. And it's not only important for that group, it is important that we identify these women, we treat these women, because afterwards, when they finish their childbearing age, they are the ones which are highly susceptible to the metabolic X syndrome, yes, and having various cardiovascular, obesity and diabetes problems. So
I think a major component, and that's what you started off with your question, as to why we are seeing so many PCOS. I think, of course, one of it is lifestyle. Probably the major component that has changed over the year is lifestyle, because the young girls of today are really having a terrible diet, a lot of junk food included in their diet, a very sedentary lifestyle, complete lack of exercise in many, many cases. Of course, there's a hereditary or a genetic element in all probability, and also the fact that we are picking up so many more cases of PCOS. Now that we have proper criteria for diagnosis and we have tests to tell us whether they are really showing polycystic ovaries. So I think we are picking up many more cases. Absolutely. And that's why it appears that the incidence is really rising.
So Dr. Kundan, how would you diagnose somebody as a polycystic patient, or are there any certain criteria which need to be included to label somebody as PCOS?
Yeah, actually, since many years we had this classification where we had a major and minor criteria, but then it was quite complicated and then it was not so user friendly during our practice. So 2008, then there was a consensus at Rotterdam criteria that was defined to diagnose polycystic ovarian syndrome, and it clearly states that at least minimum 2 criteria should be present out of 3. One is a patient should have anovulatory cycles, that is irregular cycles. Then she should have clinical signs of hyperandrogenemia, and the third one is she has all ultrasound picture of polycystic ovarian syndrome. So these are the 3 criteria, and out of these at least 2 should be present.
Perfectly. So at least 2 out of the 3. Yeah. But nowadays we see a large number of variants of phenotypes of PCOS. So frankly, although we would consider this as the gospel truth as of date, but I'm sure there will be some changes that will happen in the near future.
Yeah, because some girls are very obviously PCOS, and then when you do their investigations, for example, you don't see the classic picture, or you don't see hormone abnormalities showing up on the blood test, or the ultrasound may not show a classic PCOS picture, but they have many other features of PCOS.
If we now want to treat somebody who comes with infertility and PCOS, what are the standard tests you would like to do, Dr. Kundan?
The first thing is, at the first visit, we do a transvaginal scan and see the pattern of follicles on transvaginal scan during the ovarian screening. And second, once you have a polycystic ovarian picture, which is classically necklace pattern of the arrangement of the follicles, then we like to send their hormonal profile first, and that we have to do FSH, that is follicle stimulating hormone, and luteinizing hormone on the second day of the menses, and see the ratio between these two hormones, and as well as to see these clinical signs of insulin resistance on phenotypically. And then in that case, if they are present, we like to do a glucose tolerance test in this group of patients, because that is one of the best accepted predictive test of insulin resistance among so many other tests.
True. So although books mention that it is necessary to get the FSH ALH done and see whether the ratio is 4:1, I think if somebody 2:1, if somebody has got a classic history of amenorrhea, irregular periods, and a transvaginal scan showing polycystic ovaries, we need not do all those tests. What is important is to see whether they have hyperinsulinemia, so that you can treat them with some insulin sensitizers.
In fact, I rarely do FSH-LH, rarely. Typically, amongst the tests, I only do an AMH. So an anti-Müllerian hormone by itself, single test, the good thing is it can be done at any time of the cycle.
Yes.
Because these patients have irregular periods, and if you're going to wait for a cycle, it may come after 2 months, 3 months. So FSH-LH on day 2 really doesn't make much sense. So single isolated anti-Müllerian hormone test, if it is really elevated, you can immediately correlate it with PCOS. So that's a simple test along with an ultrasound and clinical signs. I think it's enough. In fact, like you said, the diagnostic criteria does not include any hormone test at all. So you don't need to do testosterone, androstenedione, DHT. You don't really need to diagnose that. Yes, if she has a particular problem and you're wanting to pursue that, you may do the hormone tests.
Absolutely. Now, coming on to advising these infertile women, would you straight start with medical line of treatment, or you would tell them about lifestyle changes? We talk about lifestyle, but do you think it's so important and becomes the mainstream of treatment?
I mean, lifestyle change is definitely the most important basic thing that you can advise your patient, irrespective of whether she's obese or she's thin. So that needs to be clarified, that even if she's thin, she still needs to have a really good lifestyle with good diet and exercise. That is mandatory as a supportive treatment for all else. If she's really obese, if she's significantly obese, her BMI is high, then she does need to undergo weight loss, and you can definitely defer your treatment till there is at least a 5% or a 10% of her body weight weight loss, because even a small percentage of weight loss will improve.
I'm glad you brought this up, because often patients ask us how much weight I should be losing, and there is no magic figure. It is at least 10% weight loss will dramatically change their biochemistry, and we see almost 30% of patients who become ovulatory if they have lost 10% of their body.
Brought up a very important point that at least it's not limited only to the obese patient. It is also should be applied to the average thin patients also.
But the problem really
30% patient has an insulin resistance in thin group of patients. So I think its lifestyle is required. Modification is required for both the groups.
Problem, of course, doesn't end there. It's the hardest thing to lose weight, and so very often. Even if they bring about a lifestyle change, there is not very good weight loss. Many of these people have associated hypothyroidism, making it even more difficult for them to lose weight. And so they may need assistance even to help them lose weight. So always advise them that, don't leave it to yourself. Go to a dietitian, follow a diet plan, have a trainer in the gym. So, it's a guided sort of a program. And then if need be, maybe medical therapies as well to help them lose weight.
Yeah, I think PCO is a multi-speciality management. I think as a gynecologist and an infertility person, we need the help of a dietitian or nutritionist. Absolutely. Sometimes we need an endocrinologist also to be involved in the management. After lifestyle, would you straight put them on to ovulation induction agents, or would you like to put them on some insulin sensitizers? How do you manage such things?
I think it's very individual. If the girl has a really high BMI, if supposing we've done an insulin level and she has high insulin, I typically keep 10 IU as a cutoff. So if she has high insulin, I would definitely put her on an insulin sensitizing agent. It does little bit support their weight loss. It definitely helps them during the ovarian stimulation to prevent ovarian hyperstimulation. And there is a question mark role in maybe improving egg quality or in preventing miscarriages. That has really not been proven at all, but it does. Over a period of time, we've seen that with insulin sensitizing drugs, the PCO patients often do well, particularly the obese.
Especially two groups where you have all clinical signs of insulin resistance, and as well as you have abnormal GTT. It's always better that put them for at least 2 or 3 cycles on insulin sensitizers, because that's going to bring down the androgen levels in their body, which is going to help us to improve the oocyte quality.
We used to previously think that metformin is meant for patients only in hyperinsulinemia, but nowadays, as Dr. Reshma is saying, there are meta-analysis to suggest that low-dose metformin can be given to women who do not have hyperinsulinemia, but helps them to lose weight and in fact improves their egg quality and decreases chances of hyperstimulation.
I think metformin has been controversial from a long time, from using it in every patient to completely stop using it to, again, I think a little bit of resurgence of metformin. So I think we have to individualize
and now with the availability of myo-inositols, do you prefer myo and D-chiro combination to metformin, or you think that there's a separate group that can be given these drugs?
Again, I think it's individualized. If I have a young girl with PCOS, my first choice would be a combination of mannitol, D-chiro, in the right ratio. Because for young girls, you want to really minimize medication, keep therapy a little bit more natural, assist them to lose weight, get their sort of hormonal milieu in order. So for a young girl, that would be my priority number 1. In terms of infertility, again, it's very individual. A lot of girls don't tolerate metformin very well.
Absolutely,
because there's a fair amount of GI discomfort with metformin. And so many girls tolerate the combination of mannitol, D-chiro much better. And I think in those patients at least I would
And it has been found that follicular fluid inositol levels is associated with the good oocyte quality, and especially when it comes to the ovary, there's a ratio between myo-inositol and dichloroinositol, that's 40:1, which is a different ratio in different organs. So especially when it comes to ovary, that's the ratio which is required to get a better oocyte quality, and that's why it makes sense to supplement with the similar ratio doses for myo-inositol.
And nowadays there are a lot of preparations with a lot of
added micronutrients,
especially micronutrients, so that might help at the
so you have chromium
level,
and hydrofolic acid. So all those things.
As it is, we have to give folic acid, so they may be in combination. So
vitamin D, especially in this group of
in
patients.
this group, we do see a large number of these women with low vitamin D3. So addition of vitamin D3 also helps. And there's a certain group of patients who have got hypothyroidism. So the hypothyroid patients especially have low vitamin D3. So it's always nice to supplement them. When you come to ovulation induction agents, the gold standard or the oldest drug that was used is clomiphene citrate, which is even used to this day. Are you happy with clomiphene citrate, or you think you are happy with the newer formulations that are now available in the market, considering that letrozole is now officially can be used for ovulation induction?
Right. So clomiphene has been always been a first line of treatment for PCOS patients. But of course, we know that there are certain disadvantages because of which the pregnancy rates are lower instead of having good ovulation rate. So there where the aromatase inhibitors comes in role, and they have little taken over now clomiphene, because now once it is approved in India to use for similar indication, the letrozole has really taken over, and probably in near future we might start saying, after having some evidence, that letrozole can be the first line of treatment, because it has got those, it is overcoming those drawbacks which clomiphene has. So I think letrozole will be my first choice.
Action, the endometrium lining would not be as good, and even letrozole most often gives you a monofollicular growth rather than a multifollicular, reducing your chances of twin gestation. So
I think everyone's now rather comfortable with letrozole. And you can give it in various protocols.
Yeah.
It doesn't have to be typically starting on day 3 and giving 5 days. You can give it longer. You can give higher doses. So, you can give combinations. So, lots of people are choosing it as a first-line choice, but I think that's still individual. Clomiphene is still a very good drug and may work very effectively in a large number of people.
Is there any scientific basis for giving clomiphene citrate and letrozole together?
The biggest disadvantage which clomiphene has got is a clomiphene resistance. With smaller doses of clomiphene, there is not much rise in the FSH, because of which there is no follicular recruitment. But if we administer letrozole along with it, so we at least get some follicular recruitment, at least monofollicular. Even if the incidence of clomiphene resistance will go down.
But I personally have never used a combination of letrozole and clomiphene. I would rather than combine it with a gonadotropin.
I was just coming to that. Now you do have patients whom you have given 50 or 100 or even 150 and you don't manage to get ovulation happening. So do you think these patients are right to be given gonadotropins? And what is your protocol or choice of gonadotropins? And how do you monitor these patients, Reshma?
I think very often we encounter PCOS patients who really don't respond to your first line of therapy. Lots of girls with PCOS will not respond to clomiphene. I rarely go above 100 milligrams personally, though I know you can go up to 150, but if they haven't responded to 100, it's unlikely that they'll respond to 150. So then I would rather, switch to, for example, letrozole for a couple of cycles or 2 cycles. If that doesn't work too, then definitely would go on to gonadotropins. So at that point, I think the decision comes whether you want to add gonadotropins or you want to go in for a PCO drilling. If they haven't responded to your first line therapy, you may want to add insulin sensitizers at that point. And despite these combinations, if it doesn't work, so the choice is PCOS drilling or adding gonadotropins. Because drilling is an invasive procedure, and if you don't need to do laparoscopy for any other reason, I would much rather add a very small dose of gonadotropins. So what I typically do is start with day 2 or day 3 clomiphene or letrozole, and then on day 7, the last day of the clomiphene, add a little bit of gonadotropin, so it kind of helps to maintain the increase in growth. This is for patients who are just trying either simple planned relations or an IUI. That would be the initial plan. And if that doesn't work, then of course gonadotropins from the beginning, always being very, very careful of the fact that the PCOS patients are unpredictable. They may not respond at all, and then when you increase your dose, they may completely blow up, and all the tiny cysts may start to grow, and you may get severe hyperstimulation.
Yeah, that hyperstimulation is something that we all are worried even of this date when we have certain things to reduce, which will come to a little later. But when you use gonadotropins and your patients still don't respond, Dr. Kundan, is there something to do with ALH that you would want to get the ALH down? Do you think there's a role of antagonist in these cycles?
Yes, especially what we once we start this kind of stimulation protocols, after say 6 days of stimulation, when you see that follicle is not recruiting, if you measure a LH at this level, you will generally find it that it is on the higher side, more than 5, and because of which there is it acts as an inhibitory factor on the follicular growth, and that's why at such moment, if you block the LH with the GnRH antagonist, so you will realize that if you continue the stimulation, the follicles still continue growing. The response is very faster, and the cycle cancellation rate actually goes down. So GnRH antagonist is a very important factor when it comes to COH, controlled ovarian hyperstimulation,
especially in PCOS patients.
So I think we need to differentiate because most people in a normal IUI cycle would not do an antagonist gonadotropin cycle. One, of course, cost being a major factor. Of course, if a patient is not responding to anything, then the question doesn't arise. Then you may want to do an antagonist cycle, bring down the LH. Then you have to step up your gonadotropins, because sometimes with the antagonist there is a significant suppression, and then the follicle just doesn't grow unless you step up your gonadotropin dose. So in which case then you may again cause her to hyperstimulate, because now you're giving a higher dose of gonadotropin for a longer period of time. So I think it has to be really balanced off, to go really step by step, take time. Even your increase in gonadotropins has to be very, very slow, and preferably then use pure FSH, not use the LH, because the LH is already high. So don't use the combinations of FSH LH, but use don't use the HMGs. Use pure FSH, highly purified or recombinant FSH.
Coming on to this, quite often I find that giving 1 or 2 cycles of the birth control pill, the combined oral contraceptive pill, helps to get the
one cycle
ALH
prior to the
levels down.
stimulation cycle.
And also, as Dr. Reshma said, and I'm going to reiterate here for our listeners, that you do not increase the dose of gonadotropins very rapidly in PCOS. You have to be extremely careful, because these are the very patients where you think a little higher dose will work and it blooms up into an hyperstimulation, and it really sometimes can go out of control.
So I think it's very important right at the outset to tell your patient that, the response in you will be pretty unpredictable, and sometimes a small dose will make you grow large number of follicles, and sometimes fairly large doses will end up in no response. So if you've counseled them from before, then they are less likely to blame you for the erratic response that they are getting.
Now, coming on to hyperstimulation, Dr. Kundan, is there some method that you can pick up these patients at risk? And if you can pick it up, can you do something to reduce the incidence of hyperstimulation?
No, but there are a couple of tests which you can actually do it during the follicular stimulation phase. Either you can do a E2 levels if after 5 days of stimulation, if the estrogen levels are more than 500, very likely that this is going to be either in a mild to moderate hyperstimulation. Or even if you have more than 5 dominant follicles in the cohort, especially the large follicular group, then also there is a very high chance of hyperstimulation in this group. So you can pick up by ultrasound, and you can take a help of biochemical tests like estrogen levels to predict whether she's going to land up in ovarian hyperstimulation. So these are the tests which will help us.
I think even before starting stimulation, the AMH level. So
Yes.
right at the outset, the first thing that you do is the AMH. And if it's really high, then immediately you're warned that this patient will either just blow up during a stimulation or may not even respond at all. She may be a really pathetic responder. You may need to really do a lot of manipulation with the drugs to help her bring a response.
And
So at that point, you may want to make a decision. If it's really high AMH, or if she's, had previous 1 or 2 cycles with clomiphene and letrozole not responded, you may want to go in for a PCO drilling, because you know that these patients might have a difficult time with gonadotropin stimulation as well. And so these are the patients you may want to decide that you do a PCO drilling, maybe bring down the LH, and maybe help with that. So definitely, these patients with very high AMH, you'll start very slowly, you'll increase very, very slowly your gonadotropin dose, and preferably start with the clomiphene so that initial recruitment is only of few follicles, and then add the gonadotropin so that then the number of follicles recruited is lesser, hopefully.
Absolutely. Now, when coming on to PCOD drilling, I mean, it's a very good modality in PCOS. Traditional views are that if your medical line of management fails, you should be doing the drilling. But are there some risk in the PCOD drilling that you do? Because quite often we see patients coming with really badly scarred ovaries. So is there something that you would like to tell our listeners about what care and precaution they should take?
I think PCOS drilling is something which, people have very strong views about. There are people who are absolutely against PCOS drilling, because obviously it's a surgical intervention. It's obviously putting a heat and current or intervention into the ovary, and that's likely to either cause extra burn of the ovary and actually reduce the ovarian reserve, or cause scarring and cause adhesion formation. So obviously there is a concern on that front. And there are some people who are very, very happy to do PCO drilling, because it definitely does give a benefit. And not only does it give a benefit in this pregnancy, but it may continue to give you a slight benefit even for a subsequent pregnancy which the patient decides to have. In other words, a long-term benefit. And of course, it reduces the dose of gonadotropins. If you don't give gonadotropins, the chance of twin pregnancy is less. So with that single PCO drilling, you may get long-term benefits, and then you don't need to have too much of ovarian stimulation. So I think there are pros and cons, but if you're very, very careful to do minimal punctures, just about 4 punctures, 40 seconds, 40 watts current, and put a lot of irrigation and water on it, and maybe leave a little bit of fluid inside after your
Cool the ovaries down.
Cool the ovaries and leave some fluid so that adhesion formation may be a little less.
That's ovarian adhesion is also one of the long-term complications with the
Yeah, so I think with these precautions, you should be pretty okay, especially since many of these patients need to have a laparoscopy anyway, because you need to evaluate the tubal status, or maybe there's some associated pathology. So if they're doing a laparoscopy anyway, then maybe an ovarian drilling. Very rarely or almost never will I do a laparoscopy just for the ovarian drilling.
I think for the listener, it should be a message that It should not be offered as a first-line management, especially in PCOS.
Absolutely right.
No, there are a lot of young girls, who come and, the parents say that, why don't you do a drilling, as a treatment for PCOS? There's nothing like that. It's never a first-line treatment, especially for young girls.
Yeah, absolutely right. Now, coming back onto hyperstimulation, Dr. Kundan, do you think converting an IUI to IVF helps in these patients, or putting them onto drugs like cabergoline, which will reduce the incidence? So, what is your experience on use of cabergoline?
I personally, when we are we are doing some COH IUI cycles, and if she'll end up in hyperstimulation, see, understand, converting into the IVF is sudden cost involved for these all group of patients. Not every patient is ready to spend so much money immediately. So at such moment, instead of doing IVF for such group of patients who are not ready financially, I think giving drugs like cabergoline is definitely much better, because it decreases the VEGF fluid leakage. It decreases the VEGF. And
when do you start the cabergoline, and how many days do you give it?
Ideally, if you have given a SCG trigger, then at least 48 hours later you can start. That is on the day of ovulation you can start, and at least minimum 7 days should be given, so that the effect of SCG, which lasts for 4 to 5 days, during that time you have taken care of the ascitic.
And there are good studies to show that giving cabergoline does not reduce your chances of pregnancy and doesn't have any long-term effects on the fetus also. So it's a very short dose.
Let's start just an intervention. First of all, we need to change the terminology. You mentioned out of sheer habit COH, or controlled ovarian hyperstimulation. That doesn't happen anymore because we don't want that ovarian hyperstimulation. We want ICOS, that is individualized controlled ovarian stimulation, because our purpose is not to hyperstimulate. So that's the first thing. Second thing is, you have to be, like I said, very conservative. If you're doing a planned relations or an IUI cycle, if there are more than 3 follicles, you need to abort the cycle, because there's no way you can control it. Once you give your HCG, that lady is going to rupture any number of follicles and have a multiple pregnancy possibility. So more than 3 follicles growing, you need to either abort that cycle, or then you may want to convert it into an IVF. I differ slightly in that, because if the girl is with your basic ovarian stimulation growing 5 follicles, for example, the next cycle she's going to have a very similar response, because if you've just given a clomiphene or letrozole, a little bit of gonadotropin. So I would think that in fact she's going to go through a very cost-effective IVF cycle, because with just a little bit of stimulation, if you manage to get, for example, 5 follicles, then all you need to do is add a little bit of antagonist. Antagonist today is not that expensive. You can give antagonist, and then you can, convert her into an IVF cycle, where you'll get, in today's times, a lot of people are doing clomiphene plus gonadotropin for
minimal
IVF
stimulation,
cycle,
as
minimal
we say.
stimulation. So even if you were to get 5 or 6 follicles, you would have a pretty effective IVF cycle. And, you may be able to do because the ovarian stimulation cost has almost gone away. So you can still offer a reasonably low-cost IVF cycle. Or then you lose that cycle completely by aborting that cycle.
See, what is coming out of Dr. Reshma's talk is 2 things. One is, when you start a patient on infertility treatment, especially a PCOS patient, I think it's very important to counsel the patient well. We have to bring up these issues of hyperstimulation right at the outset. So it doesn't come as a rude shock to them. They know that there are certain things that at the best of hands, you can hyperstimulate. There are options of cryopreservation there now, even in IVF cycle. So they hyperstimulate for IVF also, we can go for cryopreservation. So I'm glad Dr. Reshma has brought this up, that lot of patients can be effectively treated by converting them from IUI to IVF, provided you have counseled them before and explained that there is a possibility of this happening. And cryopreservation actually is like a godsend to us as infertility specialists. If you think somebody is going to hyperstimulate, I think it's best is to freeze all and then wait subsequently and then put them back.
In fact, even today, just now before I came here, I had a patient undergoing IVF, and patients come pretty well prepared when they, are decided to go for IVF. So she, though I did not actually talk about it because I was still doing the initial counseling, she asked me for hyperstimulation risks, that, what are my risks of hyperstimulation? I said, of course there are risks of hyperstimulation, but now, because we have so many drugs or so many systems by which we can prevent hyperstimulation, that whole discussion of hyperstimulation has now become a little bit toned down. Of course, you have to inform your patients about it. But now we know that we are a little bit more in control. Now we know that if we manage our cycles properly, probably no patient will get hyperstimulation. And really, it's I think, a relatively rare occurrence today, because especially in a cycle of IVF, when you have a lot more control, you can really aspirate all the follicles, put the patient after that on cabergoline, you can put the patient on an antagonist, or you can give her a GnRH analog depot preparation, and freeze all the eggs or embryos, and really not have much of hyperstimulation. As it is, by the 10th day, we already know how many eggs she's getting. We won't give her HCG at all. We'll give her a GnRH analog trigger if she's an antagonist cycle. So I think we have so many drugs and systems by which we can control well now, that hyperstimulation is not something to really fear anymore.
Absolutely. I mean, the day is not very far when we can actually proudly say that I have a OHSS free clinic.
Yeah.
Even now, we have somebody who comes out of the net, but I don't think the day is very far when we can actually make sure that none of our patients will hyperstimulate.
I think if you're vigilant, and the moment you see too many eggs growing, if you don't give that HCG trigger, then almost always you can control the situation. If you've given the HCG trigger, it's a problem, because HCG is long acting, unlike a GnRH analog, which has a very short half-life. So once you've given the HCG, then you cannot control the growth of the follicles after that. It becomes hard.
Where cryopreservation really helps, because you can give a GnRH agonist as a trigger and recruit all those sites and freeze them instead of transferring in the same cycle.
We now, Dr. Reshma, 10 years back, we never saw grossly obese patients in our Indian scenario, but we see them very frequently now. These grossly obese patients who are like BMI of more than 35, 38, these patients, even despite counseling, they are physically unable to do any form of exercise, leave alone dieting. So do you think bariatric surgery has a role in treating these grossly obese PCO patients? And how would you go about it?
I think the time really has changed, because we know that these girls struggle for most of their life. And by the time they come to you for fertility treatment, they've already tried 10 diets and failed. They've lost 5 kilos and put on 10. So it really is a real struggle for them. And not only is it a physical, like a cosmetically stressful for them, it's medically very, very bad for them, because they're all going into diabetes, they're going into high cholesterol, triglycerides are high, and then they have the the joint pains, the knee pain, the ankle problems.
They have a lot of low
they can't
self-esteem
exercise.
Also,
exactly.
Depression.
Most of them are going into depression. Many of them, including a girl I saw just now, obese, hirsutism, hair is falling. So there is such a negative impact on their self-image that I think we cannot be over-conservative in this. So, of course, if we have to first suggest a diet and exercise program, but all of us know how difficult it is for the morbidly obese. And so it might be a good idea to not delay or defer the bariatric surgery option too long. And I definitely put it as part of my counseling in the very obese right at the beginning. And I tell them that, look, if you don't do this, you will end up in bariatric surgery. So right from the beginning, they started thinking along those lines. And then in many situations, we do bariatric surgery, because we know that that's the only way by which they will lose 30, 35 kilos in a year. Not only that, their diabetes may completely go away, their cholesterol, their triglycerides, everything will improve, and insulin sensitivity will improve. They may just naturally start ovulating and may become pregnant even naturally. And not only achieving pregnancy, but maintaining that pregnancy safely till term is another huge thing. So a 100+ kg patient becoming pregnant, going to term, having a safe delivery is difficult. There's so many complications along the pregnancy road as well. And so I think bariatric surgery in these really high-risk group patients will be
And bariatric surgery no longer is a morbid surgery. You have gastric banding, and those bands can be adjusted in pregnancy to prevent IUGR in the baby. So there are a lot of options for these women, and nowadays it is a very simple surgery, but it dramatically changes their internal milieu. So it is safer for them to undergo even IVF because of the risk of anesthesia, oocyte retrieval, and most importantly, their pregnancy, as Dr. Reshma said, is really smooth sailing rather than you tackling somebody who's more than 110, 120 kilos and trying to deliver.
So I'll say this, that I won't even say bariatric surgery is a very simple or a safe surgery. I won't say it. It is a major surgery. But But at the same time, this group of patients is so morbid anyway, that they're going to land up with so many complications anyway, that you have to weigh the pros and cons. And many cases, bariatric surgery scores because of the multiple benefits that
especially when we talk about this morbidly obese group of patients, if we see their future life, the metabolic syndrome is the biggest problem they are going to face it. That's the biggest detrimental consequences in their life. I think this is the place where bariatric surgery is also going to help them to postpone that onset of metabolic syndrome, or even to prevent it to happen if she achieves a significant weight reduction. So I think that's the group where bariatric surgery, we should not hesitate. As Dr. Amit said, that it is now not so much morbid procedure. So we should not hesitate to offer it to the patient in this group of patients especially.
But I think before pushing them into that, we must always try full medical therapy, including, like I said, insulin sensitizers, maybe some drugs like Orlistat, proper dietitian, proper exercise. So everything possible should be tried before then we go on
only it should be. That's right.
Bariatric surgery.
More important, I think, after their childbirth and their delivery, they should understand that PCOS is something which is there with them for the rest of their life, and we have to counsel them and make them understand that they have to continue the same lifestyle, the same diet, the same exercise, so that they don't land up in metabolic X syndrome, which is really, as Dr. Kundan said, another very, very big obstacle in their life. I think with this, we have tried to touch upon various aspects of polycystic ovary in the management of the infertile woman. I think, as my colleagues have very rightly emphasized, the need for counseling, the need for lifestyle change, and the various drugs that are available to us to ensure that we get, as far as possible, a monofollicular development in an IUI cycle, and very, very few follicles, not more than 5 to 6 or 7 oocytes in an IVF cycle. We have the means. We should be vigilant in every patient who undergoes stimulation to make sure that she doesn't land up with the risk of hyperstimulation. We should keep in mind the conversion of IUI to IVF, counseling patients for cryopreservation, and at the end, in the morbidly obese patients, the topic of bariatric surgery should also be part of your counseling session. I think with this, I'd like to thank Dr. Reshma and Dr. Kundan for accompanying us on this very important topic of PCOS and infertility management. Thank you very much.
Thank you.
Thank you.